Wonderful. Okay, great. Well, thank you, Suzanne, for the very kind invitation to join you all today. My name is Erika Burger, and as Suzanne mentioned, I'm a pelvic health physiotherapist in Dartmouth. Um, I, Suzanne and I sort of through our connection at the Atlantic Menopause Show, started to talk about these connections between our very different clinical worlds. And so we thought this would be a great opportunity to actually, put some thought into this and see how our worlds actually have a lot in common. So, after a brief introduction, I'm going to talk to you about the interconnectedness of the three main diaphragms in the body: the oral diaphragm, the respiratory diaphragm, and the pelvic diaphragm, and how sort of our jobs of being the people who look in the places that nobody else looks gives us excellent opportunities for both preventative medicine and early detection. So we'll talk a bit about different tension dysfunctions that we see in our job, shared dermatology screening, and different sensory motor dysfunctions. And as Suzanne said, we can continue this conversation in June. So I've been a physio for over 30 years, and I've been a pelvic physio for a long time, from the time where pelvic physio wasn't really well known. And I think that's the thing I'm most known for in Nova Scotia is I stumbled upon this field in 2006 when I had terrible pelvic pain after a fall down the stairs in my first pregnancy. And I was a practicing physiotherapist, and I just actually could not believe that the only available treatment was just months of bed rest. I looked at my own practice and realized that me and all of the other physios I knew, the chiros, the osteopaths, the massage therapists, like all of us completely avoided the pelvic area in our work. We sort of treated people from like the head to the belly button and then the mid thighs down, and we just kept the pelvic area as the mystery it was. But was having pain in my pelvic area. And so I started to read about physios in other countries who were trailblazing pelvic physiotherapy. And I decided we needed it available in Nova Scotia. I was working in a permanent position at the QE2, and I petitioned my managers about how we needed to offer pelvic physiotherapy. And when it wasn't possible, I kind of reluctantly waded into entrepreneurship. I renovated my home and opened Nova Scotia's first dedicated pelvic health physiotherapy clinic. As Suzanne mentioned, in 2021, I moved into a much bigger commercial space, and we now have 8 full-time physios, 1 chiropractor, 1 counseling therapist, and we're all devoted to the care of pelvic pelvic dysfunction. And it's actually so touching that you have a colleague who it felt like fully comfortable to disclose that he has benefited from pelvic physiotherapy. And I think, there's a lot of people who believe pelvic physio is just for middle-aged women, but I hope you'll see from our talk that everybody has a pelvis. It's muscles, it's connective tissue, it's tendons, ligaments, just like any other body part, it has rehab potential. So I think people do kind of think that we just must teach Kegels, and thank God that's not what we do all day to be a boring job. But sometimes we do pelvic muscle training for sure. It's an important component of a treatment plan for particular pelvic dysfunction, in particular like stress urinary continence. But we actually do a lot more than that. As you know from your work, like just an isolated treatment in one part of the body is probably not going to be completely effective. We need to be whole body focused. We need to look at the interaction between, the pelvic floor and the lumbosacral area, the, hip strength, range of motion, breath mechanics. So it's really a whole body focused approach. So a kind of brief, what the heck is the pelvic floor? It's a hammock-like group of 14 thin muscles that are intertwined with many nerves. The motor sensory homunculus, of course, gives us lots of attention to the nerves in the pelvic floor for good reason. It's surrounded by connective tissue that supports the abdominal organs while playing a key role in urinary, sexual, and bowel function, as well as postural and core support. We treat many clinical manifestations of dysfunction in these muscles, and you'll see this kind of leaks like leakage and fecal seepage, urinary frequency, bowel frequency, urinary tract infections, pelvic pain, pelvic organ prolapse, bladder pain, sexual dysfunction, nocturia. So, there are many different kinds of conditions that we're treating. And so a day in the life of Erika as a pelvic physio in my clinic might look something like this. We've got biofeedback, there's a probe in someone's vagina there, and I'm trying to teach them how to activate their pelvic floor and relax their pelvic floor through imagery. This one's a rose. The rose blossoms as they relax their pelvic floor, and it goes into a little rosebud as they tighten their pelvic floor. There's rabbits that hop up mountains and dolphins that swim through the sea, different things trying to get people to understand their motor control of their pelvic floor. We're doing gym exercises, we're doing manual therapy. I treat men, I treat women, I treat kids, I treat teens. So this is sort of what my day might look like. And I don't know, this is what a Google search of images for dentist comes up with, but I'm guessing, based on my 52 years of experience of going to the dentist is accurate. So what do we have in common? Well, there's a lot that we have in common. We're seeing chronic persistent pain conditions. We're seeing muscle tension patterns. We're seeing nervous system dysregulation and dysautonomia. We're seeing tissue and mucosal abnormalities. We're seeing clinical presentations that may involve shame and body dysmorphia. And our scientific space is often clouded by social media and aesthetic marketing influence. So we're seeing people whose very specific complaints are not addressed much at all by other healthcare specialists. We're looking closely and with field observation at tissue that other people aren't looking at. And I think the other thing that's common is we're often seeing clients over many years as a trusted healthcare provider, and we're building relationships in that have a foundation of a biopsychosocial framework. So they feel safe in sharing their symptoms and concerns that they're carrying with us. So back to these diaphragms. So we do have four. I'm also a manual osteopath. So we have four diaphragms, diaphragm being a dome-shaped muscular structure in our body. We have the cranial diaphragm, the oral diaphragm, the respiratory diaphragm, and the pelvic diaphragm. And embryologically, they form together in a very stacked setup. And of course, through embryological development, they spread and separate from each other, but they really maintain this functional connection, even as there's growth of the embryo. And we're going to see this connection in my work and in your work. The people who have a chronic clenching of their jaw are very likely to also clench their pelvic floor. People who suck in their abdomen as a postural mechanism or an aesthetic look are also restricting the descent of their respiratory diaphragm through that overactivation of their oblique muscles. And in doing that, they're also really restricting the movement of their pelvic diaphragm and their oral diaphragm. So this connection rings true in my field and in your field, that this very foundational thing of what are the mechanics of the breath? And how do we retrain those mechanics? It plays a big role in the pressure management for these clients, for muscle coordination. And we see all kinds of dysfunctional motor patterns that come out of this. So the way it works is that as we take a big in-breath, our respiratory diaphragm pistons down into our abdominal cavity, changing the pressure gradient of the intra-abdominal cavity, and therefore triggering the pelvic diaphragm to also drop. So there's an oral, a respiratory, and a pelvic diaphragm all dropping together on the inhale. And on the exhale, we see like a natural recoil. These are dome-shaped muscles with attachments that are lower than the apex. So at the exhalation, there's this kind of recoiling. So I thought, because we're all here, except for people who are driving or doing things and are not comfortably seated, but for anyone who is, please put your feet on the floor, uncross your legs, have a little feel and see if you can feel. I love Suzanne. She's totally getting into it. She's like, yeah, let me get in position. See if you can feel some contact of your perineum on the chair or whatever surface you're sitting on. So perineum, you'll feel some contact against the chair. Your feet are flat. Now let's just see what we feel. So as we do a nice big inhale, we're going to feel our belly kind of come out, our ribs expand outward, changing the pressure in our intra-abdominal cavity. And as a consequence, we're going to feel our pelvic diaphragm drop and make more contact with the chair. We might also feel a kind of opening of our sit bones and widening. And then as we exhale, everything's just going to recoil up. We don't have to do a whole lot, and we'll take another deep breath. So we'll do, I won't talk too much. We'll try it a few times and just see if people can feel that, okay? So I'll give some cues. If you want, you can put a hand on your chest and a hand on your belly button, and that way you could feel a little bit what's happening. Okay, so as we take a deep breath in, I want you to feel your ribs come out to the side, your belly come out into your hand a little bit, your sit bones widen. And as we exhale, there's a nice natural recoil and everything is coming back up a little bit. On the in-breath, our side ribs go out to the side, our belly button rises, our sit bones widen. And on the exhale, we feel it all recoil and move away from the chair. We'll feel our back ribs go back, our side ribs go out, our belly button rise as our pelvic floor drops down closer to the chair. And on the exhale, we feel a little movement. So this interconnection between the respiratory diaphragm, the oral diaphragm, and the pelvic diaphragm is a very foundational aspect of this real basis of our motor system, but also our nervous system. You know, it's what tells our body whether there's danger. It's what helps cue, is there safety? Do we need muscle tension right now? Are we running from a bear or are we chillaxing, right? And so we see clients who are stuck in maybe a nervous system upregulation where their muscles are tense and they're ready to run from the bear. And they can be coming to you just like they can be coming to me for the problems that come from like clenching and holding muscles for unbelievable lengths of time. We also can see people with a really, hypo aroused system, and their muscles need a lot of cueing to kick in and do what they need to do to maintain function. But, this is the super foundational relationship. Oral diaphragm, respiratory diaphragm, pelvic diaphragm, that's at the basis of so much of the dysfunction that we may see in our practice. So we could be seeing, as I said, jaw clenching patterns, just like we could be seeing pelvic floor muscle clenching patterns. Often these are chronic. There's a stress or trauma response involved. The pelvis, just like the jaw, it's not necessarily always the mechanics of the local musculoskeletal system that's responsible for the tension pattern. Sometimes it is. Sometimes the mechanics of the TMJ or the mechanics of the SI joint are exactly what's causing the surrounding tissue to tense in response to those altered biomechanics, for sure. Sometimes, like in the case of a connective tissue disorder, hypermobility, like Ehlers-Danlos, we see muscle tension as an adaptation to create stability against the inherent hypermobility that's affecting that joint. But other times, there's an absence of that. There's no connective tissue disorder. There's no altered biomechanics in the joint, but we're seeing this incredible tension pattern anyway. And that's when we start to wonder, is this tension centrally driven by the central nervous system and maybe the ANS, the autonomic nervous system? And is this top-down tension? Is this not local tension, but top-down tension? And I think in that way, there's a lot of similarities between our two fields. Also, shared dermatology screening. Like we're looking, I'm looking, you're looking. I feel like we have the perfect opportunity to take the time and do a thorough tissue assessment. Look carefully for tissue discoloration, for irregularities, for changes over time. We have like the gift of having regular clients that we can get to know, and we can get to know their tissue, and we can make notes in our chart to remind ourselves to take a look next time, and we do this all the time as pelvic physiotherapists. And, we're seeing very similar presentations, just you're seeing them in the oral cavity, we're seeing them in the pelvic cavity. So all the lichens, the lichen sclerosus, the lichen planus, the lichen simplex. We see all the lichens. We just see them there, and you see them here. All the erythema, the aphthous ulcers, we're screening, we catch. And this is actually very sad, the number of times in my 18 years as a pelvic physio that we've actually, been the first identifiers of a vulvar or vaginal melanoma. Who else is really looking? And our clients will say that, even our female clients will say, even when I go for a PAP, I don't feel anyone is actually thoroughly examining my vulvovaginal tissue. And I would say that to be true. You're going for a PAP, they're aiming for your cervix, right? They're not taking time to look and examine everything. But I teach all of my therapists, like we're doing an important job by doing this kind of screening and taking the time and having the clinical skills to, to screen for these things. Also, another similarity between your field and my field are just these different sensory motor dysfunctions. You've got burning mouth syndrome. We've got vulvodynia. Vulvodynia is expansive through the whole vulva. Vestibulodynia is like pinpoint burning just at the vestibule, that small band of tissue at the entrance to the vaginal canal. Clitoridynia, the burning at the clitoris. We have many different pelvic pain disorders, especially different neuropathies and neuralgias, from whether the common ones you would know might be like a sciatic nerve, which passes through the pelvis, but we also have the pudendal nerve, and we see a lot of different presentations of pudendal neuralgia, which has three main branches. So you might see them more clitoris and penis, you might see more at the perineum, or you might see more like at the perianal area. But all of these kind of sensory motor presentations, they're very similar. They're hard to diagnose, they're hard to treat. There are many different aspects coming in, whether it's hormonal influence, a tissue influence, long-term inflammatory influence, mental health influence. So, we're seeing these as well in our field. The other thing that I think is really interesting for both of us is that we get to see these clients over the lifespan. And in my practice has really evolved over these years as I've adopted this view that, every pelvis has rehab potential. Well, then we're seeing pediatric kids who bedwet. We're seeing adolescent kids who can't put in a tampon. We're seeing young adults with all kinds of GI dysfunction arising maybe from disordered eating. We're seeing, women in their trying to conceive pregnancy, postpartum period. And so, I think about like the effects of disordered eating, and we're going to be seeing effects, and you are going to be seeing effects for sure. And how do we identify that in our practice? How do we get to know our clients enough to try to figure out what's at the root of some of this stuff? Hormone mediated changes. I mean, I spend all day hearing about women with extremely dry and irritated vulvas, and I'm only guessing you're hearing about their very dry mouth because this is what happens to the mucosa when there are hormone mediated changes or the use of hormonal disrupting medication, like in the case of someone with endometriosis. I also think that through this long term care of clients, we get to do cancer screening. I'm thinking about a neighbor of mine with a history of melanoma who saw his eye doctor many times with a darkened spot on his eye. And of course, the eye doctor was focused on vision, like he was there for his vision test. And did he need new glasses? And never took into account this spot, which he was very concerned about. And just last week, he finally saw a specialist and found out it was melanoma. But he had been seeing his optometrist for regular visits for a number of years, and this was dismissed. So I guess I just want to say we're there. We can be the people to look, to have the skills, to be curious and attentive to the tissue we're looking at, and really, bring early detection or prevention of things that maybe aren't quite in our scope, but we're there. Why not be the one? So I think also in that same vein, we also can be the people who really push the boundaries of interdisciplinary care and make connections. I'm here today with dentists, right? I've never talked to dentists before, just my own. But the more I thought about it, the more I could see all these connections between us. And it's a very wonderful part of our field that we can make connections and, bring about more holistic and better quality care. I think there's a lot of modern influences to consider. I did a little dive into what kind of TikTok-y things might lend people to you. There was so much stuff about the tongue. I'm like, is everyone staring at their tongue in the mirror all the time and coming to you guys with concerns about the look of their tongue? We're seeing it with people with concerns about the look of their labia minoras or, their foreskin. They're like, I don't know, there's a really heightened awareness of the look of tissue. We're going to be meeting people with a lot of anxieties about whether their tissue is healthy, is it normal, in a way that I don't think existed before social media. We had like an onslaught of like men in their early 20s booking with us about 2 years ago over a 6-month period over like a concern about the quality of their sperm. And I was like, guys, this is not, and they weren't trying to conceive. And I was like, by the time you're ready to conceive, this sperm is long, gone. Like, what are you worried about? But I'm like, are all these people booking? And then you find out in the manosphere, there's people out there, trying to create panic about whether the sperm is in the optimal function. You have to start early, 10 years before you want to try to conceive. You need to. So, I can only imagine that some of that stuff we're seeing is also some of the stuff you're seeing. So I thought I would just mention that kind of, these body image pressures and this sort of development of an aesthetic ideal that can also be bringing people and their concerns to us. So what's our role? It's really, I think, can grow and expand right now. I think how do we build these skills, build interdisciplinary connections, and build like ultimately an evidence base for better care? Um, if someone's coming to me with like a very straightforward pelvic floor muscle issue, I'm a physiotherapist, so pelvic floor muscles are my thing. Like they're coming with stress incontinence. I need to teach them how to strengthen those muscles, yes, but I also am going to be a healthcare provider who takes the time to examine the vulvovaginal tissue carefully and thoroughly, see if there are any other suggestions I can give in order to help with discomfort or potential problems to come. And I can only imagine this is true for you guys as well. So that is what I thought I would present today. And I know I'll be back in June. And I thought that if anyone had specific questions or things they would like me to explore more in June, you could share those with Suzanne, who will share them with me. And I'm happy to take a deeper dive into any of these things or other topics at that time. But thank you very much for having me. I hope you guys have a great evening together. And I'm really pleased to have been invited. Thank you.
Erika, thank you so much. I can only imagine. Hopefully, it was enlightening for you when I first met her. I'm like, wow, there are so many things I don't know. And we've got such a wide range. So, welcome to the interdisciplinary seeding of holistic human care. Thank you for bringing that forward for us. Any questions, you can pop them to me, send me an email. Erika does do the deep dives, but you can also reach her and have your own private relationship to her in her clinic. And yeah, so we're going to take a 5-minute break. Oh, Rob has a question.
I got a question. I'm gonna take my privilege as mentor here to ask a question that maybe everyone else has to go away, but I have a quick question.
Everyone has to go.
So I'm very lucky in teaching where I do because we have access to two of the top orofacial pain specialists in the new specialty of orofacial pain where I am. And it really is revolutionizing the thought process. And every day I kind of curse these people because all of a sudden I realized that root canal I did 2 years ago really had nothing to do with endodontics. It was something else. And one of the big phenomena that they talk about, and I'm starting to learn a little bit about it, is called muscle trigger point pain. And this is something that has affected the head and neck a lot. I had a patient that came in that, for examination, endodontic examination, had terrible pain the whole side of their jaw for 2 weeks, can't sleep. Classic appearance of a toothache or an abscess tooth. And yet we looked at it, there was absolutely zero anything wrong with any of his teeth at all. And so I have the luxury of being able to call over the OFP guys. He looks, pokes, does a few things, asks a few questions, and then shoots a needle in the guy's trapezius muscle, and his pain just goes, gone. Do you guys have anything analogous to muscle trigger point pain down in the pelvic area?
We have lots of, yes. So, as I mentioned, 14 small pelvic floor muscles specifically, and then all of their neighboring and associated muscles. So, we are very often doing trigger point therapy release in the pubococcygeus and the ischiocavernosus. And then, obviously all the glutes and the psoas, we're doing that manually. Externally, we're doing like dry needles, like,
Yes.
yes. And then those can be done with e-stim. And it's not a regulated part of our profession in Canada, but in many US states, pelvic physios are actually allowed to dry needle internally trigger points internally in the pelvic floor, which, again, for some clients that would be very appropriate. For clients who are in already a stress response with a trauma history, a needle into their pelvic floor might not be exactly what they need for their pain. And I'm sure these guys you're working with are also balancing out like the kind of you know, trauma foundations of some of the pain versus this guy who maybe, it's a 2 week history, pulled his trap, he was painting his ceiling or something
Yeah.
and triggered it. That's a very different than the client who comes in with a 20-year history of ongoing pain, right?
Right.
So you're always trying to get the history and try to figure out, using modern pain science. Having
Well,
pain does not necessarily mean that there's a tissue problem behind that pain.
right. Yeah, yeah, it's just the thing about this, and it's not just trigger points, it's everything about this OFP thing is what they seem to do sometimes to an old dentist like me seems like magic. You
Yeah,
know, there's a friend of mine had a patient who had terrible cold sensitivity in all kinds of teeth, just like three or four teeth up on the upper one right side or left side, terrible cold sensitivity to the point where he and her were talking about the possibility of actually devitalizing the teeth, doing root canals on all these teeth. And but he had had some training in this OFP, and he poked around and he said he could feel a trigger point in her masseter, and he needled it, and all of her cold sensitivity went away. Now, there is no real good explanation for that, and in the mind of almost every dentist. And so I asked Dr. Cohen, our big name down there, and he said, yeah, he said it all goes through the sphenopalatine ganglion and the muscle trigger point fibers going through there. They're sensitizing the sensory fibers coming in from the teeth where they all bundle in together. And I mean, to me, that stuff is just amazing. And I think it's fascinating and really gives me pause whenever I'm thinking about picking up a drill and I'm sitting there saying, is this really the right thing to do? So,
for sure. 90% of women with vestibulodynia have active trigger points in their pelvic floor muscle. So their pelvic floor muscles are up and in. The vestibule is the small, entrance to the vaginal canal. It's bright red when you look at it. You touch it with a Q-tip and they jump off the bed. The pain isn't up at the trigger point site, but those trigger points are influencing the histamine and inflammatory
yeah,
activity of the vestibular tissue. So it's very similar. And, it's very exciting as a physio, who worked in orthopedics. And I loved orthopedics, and knees are knees and hips are hips. And it was a very satisfying career. But it's wonderful to be in this field now with so much change and new evidence and new directions and new ways of thinking about things we've been seeing our whole career. So I think that is true for you as well.
absolutely.
Wonderful. Thank you so much, Erica. And
Okay, thank you.
we'll see you in person in June. Anyone has questions, we can get them to you in advance. And we'll set the timer for 5 minutes, everybody. We'll see you in 5.
Hey Rob, can you hear me?
I can. How are you doing, Ron?
Good. How about yourself? I always ask you that. That's my go-to. How are things down there?
I'm
Anything
doing great.
new?
You should use that picture of my granddaughter
I
in your travel
will
lecture.
100%. If you don't mind, I'll put it on and say who it is. Is that all right?
Yeah, yeah, no, that's great.
It's all part of the story. That's really good. That's
Yeah.
she's doing really well by the looks of it.
Oh yeah, it is. It's crazy, but it's really funny as she's starting to get
Oh,
older. She's
sorry to
starting
interrupt.
to.
Just for anybody else that's listening, it's about your
Oh,
granddaughter playing hockey. Sorry, just a context. Go ahead.
yeah, yeah. No, in fact, I'm going to see if I can show that
Oh, it's
picture
really
here. I'm
cute.
not sure
Yeah.
if it'll come through, but yeah. See if I don't know. Oh, hold
Uh, kind of coming on and off. Yeah, a
on.
little bit.
It,
And how old is she now?
there. I don't know. This background is terrible. She is. How old is she now?
7, 8.
She's 9 years old,
Is that
and
getting into quite competitive where they are now? Are they doing a little traveling and stuff too? Is it
yeah, they go. She actually has spent way more time playing tournaments in British Columbia than she has in Seattle.
okay?
And so she's up in BC all the time, and they go back and forth and have a great time with all that. It's really funny though, because all my daughter ever does is complain how expensive everything is, and she's not wrong. I mean,
At a young age. Yeah.
yeah, exactly. But her older and younger brother are both doing figure skating, and it's just funny how it works out exactly the opposite. But she's loving the hockey and doing real well with it. So We'll see how long that
Good.
lasts.
Oh, well, you know what? You never know. They're going to
Well,
ask for
I'm
it.
just worried she's just going to become a teenager and reject everything, but you know, we'll see.
Well, that's a good thing. That's nice.
Yeah. No, that's all great. And my other son, I got two sons, and my first one had a baby girl back in June, and my other son, the older boy, he and his wife just had a baby yesterday, and a little boy. So
New
now I have
news.
someone to carry on my name.
Is it a Rob?
No,
First
no,
name
no,
or
no,
just
no.
last
The
name?
last
Okay.
name, the
I
last
got
name, because
no
my
Robs
daughter.
though, is there?
What's that?
No new Robs? No, they didn't go that
No,
direction.
they were struggling for a name to the point where all the way up to the moment the kid was born, all they ever called it was Ulysses. And they didn't know if it was going to be a boy or a girl. They didn't know anything, but they just used that name for the unborn child. And then when he was born, they found out it was a boy, and they still had a bit of a delay because they had decided on a girl's name, but they had not decided on a boy's name. And it reminded me of when my daughter was born, my oldest child, when she was little, or when she was born, I mean, I should say, we did not have a girl's name picked out. We didn't have a boy's name picked out. We were just stupid. And so the nurse is standing there with the official form at the Grace
Do you
Maternity
have to have
Hospital.
a name on it to let you go? Is that a requirement? I don't
Yeah,
know.
well, they held you for like 24 to 48 hours in there, depending on the mother's condition. And by the time you left, you had to have a name. And I
Okay.
didn't know what to do. We didn't have a name, and we couldn't agree because I wanted Madeline, and my wife wanted uh, I can't remember the other, Stephanie or something like that. Um, and so I put a message on my voicemail machine, right? My answering machine, because this was before voicemail. So anyone who called during that time period got a message saying, "Look, we can't decide on a name. We've got either Madeline or Stephanie and I just threw the word Christine in there because we both kind of figured that was kind of a name that we'd both accept. And Christine won the vote. It was like 15, 20 people had called,
Oh,
and they all left their preference, and Christine won the vote. That's how we picked it and got her name. So my son had a similar issue, but they didn't do that. They were talking to some people. His wife is of Norwegian ancestry, and so they've named his first name Anders, and then his middle name is the maiden name of my ex-wife, and then Rhoda. So it's an interesting. They got the first name, which is Norwegian or something, or Scandinavian, and then we got the middle name as a last name, and then and the other one is another last name. So I don't know. They're trying to politically fix people. I don't know.
they'll probably just end up with a nickname somewhere along the
Well,
line.
I think
Go with
I
that.
guess he's going to probably be called Andy, but on the other hand, a friend of mine said he's just going to get beat up a lot as a kid.
Enders. No,
Anders.
that's okay.
No, it's okay.
All
Well,
right, that is 5 minutes, so we're going to get started. Rob, you'll give us a little break all the way through, um, so people can move their bodies and all of that stuff. I'm just going to pin you.
Okay,
Elvis.
We can see your slides. Yeah,
good.
have a wiggle break. It's a long day for everybody. But apparently, I don't have to pin you, so that's also good. Can spotlight you for everyone. I don't have to probably do anything. Just making sure. Well, I can see Ron. You can see Rob's slides.
Yep. It's good.
Excellent.
Cover slide.
Okay, Rob. So you're on.
All right. Well, good afternoon, everybody, or evening, I guess, over on the East Coast. I'm again, really happy to be here and glad you're all here to listen. In the last two presentations, the first one